Excited to be here with Susan Collier, who I started teaching the joint replacement program with. I'm not going to say how many years. It was over a decade ago. And it's been an absolute privilege working with Susan, watching us both grow with the program. And I can tell you, we always called each other a partner in crime. And what was awesome was, maybe Susan knows this about herself or not, but she has incredible research skills, and she's very diligent about putting amazing exercise programs together. And it was just great working with her. And what's really, really interesting, and the reason I wanted to bring Susan here for all of you, is she lived with knee arthritis a long time. She was the lead trainer in a community joint replacement program with me. And that whole time she was helping other people with hip and knee replacements, pre and post-op. She was dealing with knee arthritis herself. But the unique thing is, over a decade later, she now has the perspective of being a knee replacement patient, or knee replacement
recipient.
Recipient is the correct word. So what's so exciting for both trainers and both recipients or people living with knee arthritis is Susan has a perspective of both being a personal trainer, training clients with these conditions, but also she has now experienced it firsthand. Oh my gosh. So she's going to share with us her information. So I really want to thank you for being here and really sharing all your experiences and all your knowledge with us.
You're very welcome. My pleasure.
So last time I spoke with you, you shared with me a bit about your experience with it. And I kind of wanted to start with, pre-operation preparation and kind of what you did to prepare for your surgery. And if there's anything specific you prepared that you want people to know about that really helped you.
Okay, I have a lot of detail, but I'll try and be as brief as possible. Okay, so what I did is I thought about it and I thought, well, physically I prepared by staying as active as I could pre-operatively. So I rode my stationary bike almost daily, and I did all the pre-operative exercises that are outlined in our joint replacement manual. So those that were appropriate to my strength and my preparation. So that's what I did on a physical basis.
Okay, and you always managed pain with the exercises? And
surprisingly enough, I experienced pain at the end of a day, or I experienced pain when I went up and down stairs. Towards the end, going up and down stairs became literally, it wasn't worth the pain, so I didn't do it. But I didn't have a lot of pain because during the day when I was working, because I was on the level. So I didn't have to change elevation or anything. I just kept walking on a flat surface. So I didn't even take Tylenol. I did I'm just trying now, I'm lost, for a topical solution, arnica. I applied arnica to my knee joints, and that seemed to see me through the day. And then when I got home, I did more. And then I also used an alternative method to reduce muscle tightness. And I'll talk a little bit about that later.
Okay, excellent. And I know, I don't know what it was for you or if you found your own amount, but previously in training clients, I would always kind of educate them on, you've got to find the right volume for you. Like, I know you were working and on your feet and coming home and doing things. Did you find you had a certain volume of exercise? Like you said, you might maybe be in pain at the end of the day. Was that a concern for you, like how much you did in the day pre-op?
No, it wasn't a concern for me, because using this alternative method of controlling sort of muscle tightness, that would relieve all of that at the end of the day. So I'd start every new day fresh and ready to go. So I think that was very significant in my ability to handle the discomfort.
Wow. So maybe we'll talk about that right away, like how you relieved muscle tension.
We can talk about that. I have to refer to my notes, I'm sorry.
No, that's great.
Yeah, I used something called...
I might take notes too.
Okay, so I used what is called PEMF technology, which is pulsed electromagnetic fields, or pulsed, so electromagnetic therapy, which is applied to the body to correct imbalances.
Okay.
And it's just, you lie on a mat for a certain period of time. I came down to probably 2 8-minute sessions, one in the morning before I left for work, and one at the end of the day when I got home. And it's a mat, and I just lay there and do nothing, and I could actually feel those muscles relaxing. And that was it. Very simple. So the mat is sold by a company called Swiss Bionics. And it does a lot more than really, it brings the body back to neutral or normal.
And I know it's probably new for a lot of people listening to it. There is a whole science behind it, correct?
Yes, that is correct.
Okay.
And it's very complex, and I'm not very good at trying to explain it.
That's okay. So I think that's really great. You brought up an alternative method that you use that really helped you. And I think what might surprise most people is they don't have to exercise with this. You're literally lying there on a mat, but the mat has PMF in it, right? Or
Yes.
is the method of PMF.
That is correct. So it's run by a small iPad. So you just set the iPad for the intensity that you would want and the time that you want. That's it.
Wow.
And then you recharge that iPad periodically. That's all you have to do.
Okay.
So unfortunately, it's a very expensive solution to problems, but it has a lot of other medical benefits.
Excellent. Okay, yeah, I know it's cellular and it gets you back into homeostasis. It's very healing.
Yes.
And it's actually great for pain relief, right?
Correct.
Okay.
Correct.
Thanks for bringing that up. Now, if you hadn't done exercise and only used the mat, do you feel you would have had as good a result as you did? Or it's the combination of the two?
No. You have to have the combination of the two.
Okay.
You have to do your regular strength exercise. You need to do, for me with the knee, most important to do cycling, so non-weight bearing. On a daily basis as much as I could, and get that synovial fluid going in the knee joint, and then stretching. So, all three of those things. I would not have been strong enough to, I could have survived the surgery and recovered, but then I'd have a long way to go to build up that strength again. Right. And as we know, when your joints aren't working properly, your muscles tend to turn off anyway.
Yeah.
So you need to have some muscle memory there for when you're finished your surgery.
Okay, excellent.
Otherwise, it's a long road to recovery.
Yeah, and I know I wanted to ask kind of what do you feel has been the most integral to your recovery? Either share with people kind of the steps you took, or if it's one specific thing. What would you say has helped in your recovery?
Keep on reinforcing range of motion, to keep moving. The minute you stop moving, you're in trouble. Even if it hurts, you move, right? And it's a little bit when you start off, but then you just steadily increase to where you can tolerate that movement. Having integral, again, having access to a bicycle, because that really helps you with your range of motion. You start off with your seat set very high, and you start working on the very first revolution, which probably takes quite a while in terms of minutes. Like the first day I got on the bike, it probably took me 10 minutes of cycling backwards to get the revolution that I needed. Once I got over, then I kept going backwards. And I did that for 6 to 8 minutes, and then I started going forward, but I didn't do it as long. But the next time I did it longer, going forward. But I always started in reverse.
So you could go backward easily first, post-operation, and you had to do that in order to be able to go forward.
Correct. And then as I progressed, the seat started to come down lower and lower. And that was really under the guidance of a physiotherapist. And while I thought many times, there's no way when he lowers that seat, I'm going to get that revolution, I did. You just have to keep working at it. And it's uncomfortable, but there comes a point where you're almost over the top and you just keep going until you get over the top. And it's such a satisfying feeling that then you're off to the races.
And it seems so counterintuitive. Like you said, there is going to be pain. And I know you're talking kind of immediately post-surgery, like in the weeks after it.
I would say 3 to 4 weeks, yes.
Okay. And I mean, by the time, if a trainer's listening to this, and we're talking a little bit about pain here and pushing through pain, you're actually saying you needed to push through the pain in those first 2 months to be able to get a forward cycle.
You have to push through some pain, but your pain is controlled pain, i.e. you are taking either a painkiller that's prescribed by the doctor or a Tylenol. So they don't want you going sort of, it depends on the institution and where you've had your knee done. But for me, it was never go beyond a 4 out of 10 for pain. So I had to start my exercise sessions at a 4 out of 10. And you get pretty good at determining, you know, what it is. At the beginning, it's hard to gauge it because there's a lot of pain. But pretty soon you get it down to, okay, I can cope and I can be reasonable and I can move forward and I can do a bit of exercise. And then you can also tell towards the end of 3 to 4 hours, uh-oh, I'm in trouble. I need more medication or Tylenol or whatever.
Okay. So the pain is regulated, and you're also in that first initial stages post-op in the first 3-4 weeks where you're pushing through pain, you're under the guidance of a physio as well. And you're sitting higher up on the bike and then gradually lowering it.
Yeah. So for the first 2.5 to 3 weeks, I was not on a bicycle. It wasn't until I finished my physiotherapy at home, and she felt that she could do no more. I needed to graduate and move on. And the very first, when I went to the outpatient physio, the very first day I was on the bike, whether I liked it or not. It's like, you can do this. Don't worry about it. It will come. You'll be good. And then as soon as I did that, I went home. And so the next day I did not have physio, but I had a bike at home or in our gym. And so I went to the gym and started practicing that reverse again. Set the seat as high as I could, and it worked, right? So then the next time I went, I wasn't so fearful about, oh, I'm not going to like this or it's not going to work.
Yeah.
Yeah.
Yeah, that fear makes the muscles tense, right?
Very tense, yes. And the first physio that I had at home, I did have to endure a lot more pain than I did at the outpatient physio. The outpatient physio's philosophy was, we don't do pain. We have to, or it's managed pain, right? Whereas the in-home physio really pushed me to the edge. But I think it's because I had IT band pain. And so it was not so much the joint that was bothering me, but the IT band.
Okay.
Having
There's
said
always
that,
compounding issues.
yes, there are, and it was a compensating thing for me with the IT band being so tight. I truly believed I would never get over that. That's how severe it was.
Wow.
But magically, at about 4 months, it started not being quite so bad because my other muscles were getting stronger.
And that's the key.
That's the key. And I never thought it would happen. And then all of a sudden one day it's like, wow, my IT band isn't hurting me. And now it will hurt me if I go on a long walk or do a long ride, but I know how to stretch out, and I haven't had any problems in the last 2 months.
Okay, great. That's awesome.
Yes.
And I know for a lot of people listening, IT band issues are quite common, actually, for both knee and hip replacement, pre and post-op. And as you heard Susan say, strengthening other muscles and getting muscular balance rather than the imbalance can help correct it, and time can correct it, right?
Yes. Yes.
Okay.
So the other integral to my recovery, stretching, and then not every day is better than the previous. So in terms of gains, you're not gaining just because you're exercising on a regular basis doesn't mean that today or tomorrow will be better than today, etc. Sometimes you level out and you're flat and you think, I'm not going anywhere. I'm not making any gains. This is horrible. What am I going to do? I need to do better than this. And then all of a sudden you have another first, right? Being able to get your backward revolution in 2 rounds rather than 10, right?
You have to mark all those progressions.
Yeah. So that's another one of my points, is that you really need to write a log every single day post-operatively, and it's a real pain, and you lose enthusiasm as time goes on. But you honestly, there is so much going on that you honestly do not remember what happened last Tuesday or what even happened yesterday. So it doesn't have to be a long log. You just have to write down what are the significant changes that have happened, or what you did physically that day, how you felt that day, if you were tired, how your meds are doing. And also on the topic of medication, you were taking so much stuff. Again, you do not remember. So if you don't write it down, you go, did I take that at 2 or did I take it at 4?
Wow. Great advice to log and document and track for a number of reasons.
Yeah, and if you don't want to do it, get someone else to do it for you.
Okay.
Right. So often, if I didn't feel like doing it, then I would have my daughter do it, especially if I was working through exercises. And the other thing I did is that I wrote down all of my exercises. So I wrote it on a spreadsheet. My husband did this for me. He put it all on a spreadsheet so I could see the progress and I could see if I missed anything. Because again, as you're working through important exercises, you go, well, did I do it or did I not? Or did I do 10 or did I, do 20? You don't remember.
So important that you shared that, like just tracking so that you can see you've done it or you haven't, and excellent.
Yeah, so I would say that's very, very important. The other thing is respecting pain, like keeping it under control, resting and icing. And having a good support system is integral to your recovery, whether it be family and or friends. And you cannot be, I'm very adamant about this, you can't be shy about asking for help, because for the first 2 to 3 weeks especially, you need all the help you can get. You need help, whether it be shopping, cooking, or whatever, because you go literally from being very dependent to independent. And that's a hard pill to swallow as well.
Yeah.
Because you don't feel like you can do anything without asking permission or notifying somebody, that you're leaving the room or you're going to walk from A to B.
And that's great advice of having support. Would you say that's like up until 2 months post-operation, or how long do you feel people should have that?
Well, I had the support right up until 6 weeks. But then my husband was there with me. But super support from probably day 6 through to 3 weeks.
Okay, that's excellent.
And the other thing is your caregiver can get very tired because you're on a regime of medication. So generally you're taking it every 4 to 6 hours. And then if you have an antibiotic that you have to take, that regime is different than your pain regime. So then all of a sudden you get 2 hours of sleep on one cycle and 4 hours on the next.
Wow.
So the caregiver gets tired and impatient, and do I have to carry on? So you need a substitute as well. Somebody who can come in and go, I can do that for you, or let me get you and make a dinner for you, or go get your groceries or whatever.
I'm really glad you're bringing this up, and I actually think this is a good point to discuss this. We know, we've heard in the news, and we know it's going in this direction, that they're bringing the 1-day knee replacement in and out of the hospital in 1 day. Good side, great. You're not going to be exposed to germs and you're going to be out. But our worry, and I know you and I have discussed this, is, in and out surgery, it's day surgery. I'll be good to go, no problem. And so I don't know if you want to share some of your perspective on that, because I thought this is a good point to bring that up, because you're saying, look at the recovery it takes, look at the support it takes, look at the impact the meds are having on you. So do you want to share your opinion on that?
Yeah, I think the done in one day is, I thought about this last night a lot. It's great for the doctors. They get you in and they get you out. It's great for the hospital because they get you in, they give you the protocol for your follow-up, gets all written out for you and send you home and let somebody else worry about it. It's not so great for the recipient. So you go home on day one and you feel fantastic. You can bend your knee at 90 degrees or whatever, and you go, wow, this is just a piece of cake. I don't know what anyone's talking about. And then when all that medication wears off, because they give you, not only do they give it to you orally or intravenously, they put a lot of medication into the wound, right? So that you're not going to have a lot of excessive pain either, because it's pretty major surgery, even though they accomplish it in a short period of time. So day one is great. Day two is, oh my goodness, I have a problem. This is not fun at all. And if you don't have a support system at home, you're in big trouble, because then you say, well, I'm in so much pain. I don't know what to take, or I take too much and I'm not going to do my exercises. What does a couple of days matter? I won't do them for 3 or 4 days. Well, it does matter. You need to be moving that. And they give you the very basics, like heel pumps for your circulation. You've got to do those all the time. Even though you are on blood thinners, you still need to do those heel pumps. And then you have to do, work on your flexion. And it's minimal at that point, but you need to do it. And the other thing you need to do is keep your legs straight. And that can be very difficult if your calf muscles are tight, and generally speaking, they are. Yeah. So yes, it's great, but personally, I don't think we have the system to support that. It will evolve like how other surgeries have. But at this point, I'm very cautious about it.
Yeah, thanks for sharing that. And I think our point here is, as it goes that way, our big takeaway that we want people to know is, yes, you're in and out in one day, but don't let that minimize the extent of the surgical impact for you. And the way you can prepare for it best is to have support at home, whether you have an in-home physio, whether you have, if you're living on your own, make sure you have a care aide or someone come in, or a family member, whoever you can, come in and help you get through this, and know what to expect, right? Like, know the pain, and know you need to move, know you need to do the ankle pumps, and the range of motion of, you said, keeping your legs straight, and also work on flexion. So we don't want people to just think, okay, I'm in and out, no problem, back to normal the next day. It's a serious surgery, and there is a length of time of recovery that takes a lot of work.
Yes, yes, and you don't want that scar tissue to build up and then not be able to move your joint. And that does happen.
And movement right away helps prevent scar tissue, correct?
Correct. Yes, it does. And movement also helps to prevent clots happening. So there's, again, a very fine balance between keeping moving, doing your exercises, icing and resting, elevating, getting that medication. So it's a busy, busy time with not much sleep, which you really need, but you don't get, because sleep helps you repair, right?
Yes, you really do need it.
Yeah.
What would you say has been your biggest challenge, whether it's pre or post-op, just your biggest challenge in it all?
Biggest challenge. I've got quite a few, actually. Retraining the brain and the muscles, i.e. you establish patterns of movement, and then all of a sudden it's like, well, that doesn't work anymore. So for me, my right side was very dominant. I had my left side done first. And trusting that the left side would work, and would work without discomfort. So going upstairs is a good example. I always led with my right. Now, because my right is not good and waiting for surgery, I need to lead with my left. And as time progressed, that movement, well, first of all, the strength came, but also the movement is you move that joint and you go, oh my goodness, there's no pain. And it's very weird, because you you've accommodated your pain level, whatever it may be, up to surgery. Once you start to get better, it's like, wow, I can do all this. I can bend and there's no pain. So trusting that. So retraining yourself to do things in a different way. And I had an instant today where I went to see about my bike, and the fellow at the bike shop said to me, it's time you changed your pattern. And I said, you know how difficult that is? He said, you need to learn to push off with the other leg. And I said, that will probably take me the rest of the summer to figure out how to do it and trust that I can do it. And he said, well, you know that the strength now is all in your left side,
Yeah.
and not the right side, which I'm accustomed to using.
And there's probably some automatic conditioning of favor that side. And that's why you're saying it's so hard to retrain the brain to trust it and now use it so you protect the other side, which often happens for people.
Yes. And even your gait pattern, right? Retraining how you walk, thinking, okay, you know, I need to get that heel strike and I need to get that push off. So retraining muscles.
Okay. That's a good one. And we see that.
Probably another, gaining confidence to weight bear without, so that was huge. Starting to walk again and trusting that I wasn't, because you don't have strength initially, trusting that I had enough strength to go put one foot in front of the other. So then I began to use the walker, and I trusted the walker. But then it was, okay, now I have to give up the walker. What am I going to do? And I was quite afraid to take those steps without the walker. So I started doing small areas. So if I got out of bed, I would walk around the bed, or I would hold onto the wall as I went to the washroom. Or if I was in the kitchen, I would walk around the counter. And pretty soon it was like, oh, okay, this is easy. I'm doing it. But it was very fearful. I was very fearful at first.
Which makes a lot of sense.
Yeah. And I was also fearful of coming off that walker, and I did not go onto a cane. I went onto walking sticks.
Excellent.
And I discussed that with both the home physio and the outpatient physio. And they were both very supportive of it, because they felt that using a cane was one-sided, and I was far better off having support on both sides. And I felt that. So I used the big tip urban pole. So I had lots of support when I walked.
So it's like the walking poles, for those people who might not know what you're talking about. It's the walking poles, and you use, that's called urban poles.
Urban poles, yes. Yeah, so they have two style of poles, but it's the activator, which is for rehab purposes, and that's where I started.
And when you said the bottom of the pole, it's like a boot, right? It's a wider base, so it gives you a bit more support.
It's a bell-shaped bottom.
Okay. Excellent. Yeah, those are fabulous. For anyone listening, they're great.
And then biggest challenge, and moving through the IT band pain, which I already alluded to, was far worse than the joint pain itself. That was a big challenge. So I had a few.
Okay. And
counting on.
Yeah, but there's always the unexpected surprises.
Yes.
So how many months post-op are you right now?
5.5 months.
Okay. And what is your exercise routine right now?
My exercise routine is to ride the bike. So I have a stationary bike. So that's another thing. What I found in the physiotherapist, I rode an upright bike, and it wasn't super comfortable for me, but I could adapt to it quite well. I could not ride the recumbent bike, which is where everyone wanted to steer me initially. And it wasn't so much that I had pain doing it on my new knee. It was pain on my to be operated on knee. So I could not tolerate the discomfort on the extension with that right leg. So I had to find, okay, now what? So I tried the upright. It was okay in the gym, having the big upright, but what was most comfortable for me was the spin bike. Oh. But again, so yes, that was very, very comfortable for me. So as soon as I could do it, I used it at home, And then when I went to physio, I had to use his bike. But I would say spin bikes, if you haven't been on it, post-operatively, it's not time to start without guidance because of the flywheel, right? You don't have a brake system, right? You have to slow down and use the switch.
Yes.
Yeah, and you do not want to jar your knee under any circumstances.
Okay, so you're doing the spin bike and then you're doing
and then I do strength
right
exercises, and then at the very end I do stretch. And
you're
actually
doing...
I start off with a couple of stretches, a hamstring stretch, and then letting my knee fall into flexion, and that was given to me by physio, just to get that movement and get that flexion as far as I can go, and it worked like a charm. So I do 3 of those in a row, and then I'm ready to go. So I may do that before I step on the bike, and then I get on the bike, and I still do the backwards first just to warm up, and then I go forward. And so I'm 20 minutes to half an hour, and I'm starting to increase my resistance, but I need to work harder, as evidenced by my outside biking on the weekend. I'm not strong enough, so I have to move it up a bit.
Okay. And in terms of strength, you're doing at 5 months now, you're doing weight bearing strength exercises.
Correct.
Too?
Correct.
Okay.
Yeah.
And even though it's your right knee that you're waiting for that has arthritis now?
Yes. Yes.
Okay. So the right is non-operated. It's able to tolerate your weight bearing exercises?
No. No. So if I'm doing step ups, I will step up on a low platform with the right knee, and I will raise it for my left side. So I can increase. And then for eccentric lowering, I will do that on my new knee, but I would never go through with it on to be operated on knee, because I don't have ACL or MCL. So I slip and slide all over, and it's very painful. Okay. So I've had to adapt. The same at work with the shuttle.
Yeah.
I can do a 2-footed shuttle, and I'm working up. I need to work a little bit harder on that. Okay. However, single leg, again, it's the same story. I can do more on the left than the right. While you don't want to work too hard on the discrepancy there, you don't want to get too far ahead on the left so that the right is way, way behind, because you'll never catch up.
Yes. And thanks for bringing up that you're working now. So, I mean, we've told you guys the challenges to really make it realistic, and also to debunk the in and out in one day. But the good news is, for someone who's willing to do the exercises and he prepares and recovers, can you just share at what month or what time frame you felt you were able to go back to work part-time? And because you stand on your feet, just so everyone knows.
Okay. I aimed for what did I aim for? I aimed for 2 months, which was not realistic.
Okay.
And that was driven by the fact that I met the lady who takes your blood in the hospital.
Yeah.
She had been back to work at 2 months, and I thought, well, if she can do it, I can do it. And she admitted to me that she had not been conscientious about her exercises. So I thought, well, if I exercise a lot and do everything I'm supposed to do, then I will be back at that stage. Well, I came home at 6 weeks from the States, and I was another 3 weeks before I started to work, and I did it slowly. So I did 3 days in a row, but I only did an hour per day. But that hour really is not a true hour. It's more like an hour and a half, right?
So after about 2 months, you were able to go back to work standing for about an hour.
Yes. Okay. And then the challenge there, Jody, is that you will swell up. So then you have to go home, elevate, and ice.
And what would your advice be? So if someone needs to go back to work sooner than later, and is in that position at 2 months, if someone was seated at work, do you think they could be back at work?
You get a lot more swelling from my experience when you're seated. So when I went out for a social evening and I sat, my leg would balloon up and everyone would look at me and go, well, you're sitting doing nothing. Well, that's the point. You're not circulating.
Wow. So it either had to be elevator, or you need to be walking to.
Correct.
Okay.
Correct. So really for me in a walking standing job, that was actually better for me, or better for anybody, than sitting at a job at a desk.
Okay.
So for that, I would say 3 to 4 months minimum. And then you also get the question of, I had someone approached me the other day, when can I start golfing? And we used to go, well, 9 months to a year. Now it's probably a little earlier. But I said, well, if you go and do a little pitch and putt, you're probably going to be okay, but you can't get into any serious golf. And as far as a full on 9-hole golf game, you're going to be somewhere between 9 months and a year before you're super comfortable.
Great. It's a good picture to paint for people so they know what to expect and not to be discouraged, because we would see that all the time. People are like, why aren't I better? And I should be better. And even what you said earlier about it's not always forward. Sometimes there's bad days, right?
Yeah. Yeah. In terms of exercise regime, one of the points I wanted to make is that you are always working on your extension and flexion. Just because I am 5.5 months along doesn't mean I can ignore it, because you stiffen up. So if I'm out walking, my calves can tighten up, my quads can tighten up. And then it's like, oh my goodness, my bend, where is it? You know, it was fantastic, but it isn't there right now. So you have to go through the same exercise regime of doing your flexion or extension.
So important. And there's specific exercises for flexion and extension, and there's also stretches that help it.
Correct. So calf stretching, easy to do.
Yeah.
Right?
Yeah.
And my calves were very, very tight post-operatively. They still tighten up. And so when my new knee feels a bit funny, I think, uh-oh, need to stretch. I mean, I know it right away. And then as soon as I stretch, I'm good to go.
So stretching is very, very important.
Extremely.
And range of motion is very important for me.
And one of the things that I have been negligent about is hip flexor. You can be super tight. You know, your quads are tight.
Yes.
You tighten up through the hip flexors. So again, that's one area that I pay attention to now. And I also, in instructing class, I mean, I always end with a really good hip flexor stretch, just standing and just stretching all the way up the one side and getting that nice feeling through there.
Great. That's a great point. It makes such great sense. Like if you think about it beforehand, you're favoring the leg and you're probably not moving it in its full range. So it's shortening. And then post-surgery, initially you've got swelling, so your leg is heavier. So now the hip flexor is short, and now it's lifting this heavy leg that it wasn't as heavy before because of all the fluid until that's gone. So it makes great sense that you need to be stretching that.
Yeah, that's a really weird feeling to have. You have this leg which is really heavy.
Yeah.
You know, the first time they say, okay, I just want you to stand and I want you to flex that knee. And you go, I can barely lift it off the ground. It's heavy. Even in a prone position, lying face down, you know, bend the knee. Really? Are you kidding me? I need some help.
It's a foreign leg, foreign object.
Yes. And it wasn't probably until 5 months that I could, with sleeping at night, putting a knee between my pillows, I don't feel my knee anymore, but I certainly did up to then. Okay. So I'd always have to have that pillow for comfort. But now I don't think about it at all.
Excellent. Good progress. Some of these timelines are so great for people to realize, so they kind of have an average or a norm of what to expect. You could be better, it could be longer. There is no exact. It's really so relative to everyone's body. Also, would you say like the preparation and your recovery also make a big difference? Like your action in that, your action in doing the exercises?
Yes.
Okay. Was there any surprises along the way, like good or bad, that you're like, wow, I didn't expect that? Or
Um, the biggest surprise. Oh, the biggest surprise was how difficult it was for the first 3 weeks. So I had no idea how basically for me, and this may be very individual, it took every ounce of everything I had to get through those first 3 weeks.
pain-wise?
Pain-wise, not having enough sleep, taking medications which don't make you feel particularly good anyway. And also I had a very tiny, so I had stitches. In Canada, they often do staples, and it doesn't really matter. They're both difficult to get out. But I had a stitch that was trying to come out. So it was embedded in, but now it was trying to come to the surface. And so it started a bleed, and it's tiny, tiny, tiny. But anything like that, they look at you and go, if it's a pinprick, it means you're back on antibiotics. So just all the things that you have to do for that first 2 to 3 weeks, I found overbearing.
No,
and I'm not looking forward to going again. And the surgeon said, I can do you at 3 months if you want, and just get it over with for the next knee. And I looked at him and said, there is no way mentally I could handle it. Now I'm getting to the point at 5.5 months is, okay, I could probably do it. I need to do it. Yeah. The discomfort and the inability to do what I want to do physically is enough to drive me towards doing it. And I've likened it to what it's like to have a baby. The first one, you don't know what you're getting into, and then you go, whoa, what was that about? By the second one, you go, okay, I know what to expect. And that's what it's like with the second knee. You know what to expect. You know how to manage it. You know it's going to be rough, but you know you'll get through it. Whereas the first time, you don't think you will get through it.
Wow. You brought up some really good points there. I think people need to know, like around the incision and managing the incision, that the reason that they were concerned about that stitch is there's big risk for infection. So even the slightest opening, even near a stitch, is of concern, and that's why you go on antibiotics.
Yes.
Yeah.
Yes. And so you just finish your course of antibiotics, and then you're told you have to go on again. And they don't always make you feel good. And unfortunately for me, I had a reaction. So that wasn't good either.
Yeah.
So this time I will have a different course of antibiotics.
And I think
probably,
you've given people, do you think if someone had shared with you, like you've given people some mental preparation that the first 3 weeks are going to be very challenging, do you feel if someone had shared that with you, it would have made it any better? Or no, you like having a baby?
I think it's one of those. I think it's one of those realities that you have to walk in somebody else's moccasins before you get it. So what it's done for me in terms of working with my own clients, it has given me a huge appreciation for what they have gone through to get to where they are at when we see them at 6 to 8 weeks. They have been climbing mountains to get to that point. And so I have a huge respect for that. I didn't have that before because I didn't know.
Thanks for sharing that, because some of the people watching this are personal trainers. And I know you were a personal trainer who was training people in the program and with hip and knee replacement, and now you're a recipient. So you have a really unique perspective of the knowledge and the know-how and all that experience and years of training people, but now you have your own experience and you're a recipient. So how would you say has that changed? You just talked a bit about the empathy and respect for clients. Is there anything that's changed for you in your approach, or anything you would like trainers to know who are training clients?
I think, yes, I think the trainers have to, when they meet people that are pre-op or post-op, they have to ask a lot of questions. And maybe we can come back to injections prior to pre-op, or yes, prior to pre-op, because I need to mention that as well. Ask a lot of questions. Say to people, tell me about your experience, tell me about your pain level, tell me about whatever. Asking if they know, trying to get a feeling for what kind of preparation, and it's really not our job as trainers, but you also want to give them a little nudge as to, okay, maybe these are some of the things that you need. You know, do you know about the medication you're going to be on, or do you know about how long you will be on medication, and will you still be using those meds when you come and see us at 6 weeks, or what kind of medication you're going to be on. Have you had any previous experience with surgery? How are you feeling about that? How are you, how do you have the help at home you need? Do you have the support system? Do you have a ride? Do you know how you're going to get into a car post-operatively after your surgery? Have you tried it? Do you know that you're not going to be able to bend very much and you have to get in either the back seat or the front seat? Have you even tried and had a practice run?
Get them mentally preparing and
just, yeah, just helping them prepare for things. And I mean, yes, it's not really in our
scope
of practice. However, I sometimes wonder if we can't sort of sow the seeds, then it's not going to happen.
We can, and you and I used to do that. We would say, you know what, here's some, we're not experts. Here's the questions you need to ask. Make sure you're asking them.
Yeah. So for me, I had 25 questions when I went to see my pre-op surgeon. And not everybody's going to have those questions, but if you have someone who's been through the experience, then you can say, okay, well, what did you ask? What are the kinds of things you were concerned about? Yeah. For me, I just picked up our joint replacement manual and I went on BoneSmart.
Excellent.
Which is, I thought, really good, and they've got a good forum on there as well. So you can come up with, you know, questions or concerns and things that you probably haven't thought about.
Terrific.
I'm meeting a lot of people now, almost on a weekly basis, who are having injections. So I don't know what the name of the injection is, where they put in a fluid to give you more movement in that joint, which seems to satisfy the level of pain, or you have less for a while. That seems to see you through. And I'm not sure what the name of that is. And then there's the next level, which is called platelet-rich plasma.
Okay.
And so if the first one works, but only works for 3 months, they go, well, maybe we should try the platelet-rich plasma. And they'll try that. And then if that doesn't work for very long, they'll go, well, we've been working with stem cells a little bit. Maybe you'd like to try that. Well, the cost goes up. The first injection might be 50 or 60 bucks. The second one might be 400. And then when you get to the stem cell version, then it's going to be more. What I gathered from the workshop on BoneSmart that we looked at a couple of months ago was that stem cell is still very new. And although some medical facilities are touting that, oh yes, we do stem cell and we're really good at it, I would really, really do my homework before I said yes to that. And the other thing is that you cannot have any of those within 3 months of your surgery because there's a risk of infection. There's also a risk of infection when you have those injections. And so you need to ask the questions about infection.
Great. That's great feedback. In terms of any extra advice you have for trainers in understanding people who've had, we're talking about knee replacement for you, I'm sure it's similar to hip replacement, but do you have any specific advice now that you're on the other side of not just being a trainer who does it, but being a recipient, that you feel is really important for trainers to know who are training clients?
Other than asking lots of questions and always being, how do you feel and what is your pain level? So if you give them an exercise regime, it's, are you experiencing pain? Yes or no? If yes, how much? Also, you want to, if they need both knees done or both hips done, there's a fine line with keeping outside of or not doing weight bearing exercises versus doing weight bearing. You know, if you can preserve that other side because it'll be a year and a half or 2 years before it gets done, then you want to strengthen to a point, but you've got to work with both the new and the old, but always asking for those temperature gauges. How are you feeling? What's your pain level?
Excellent.
And also asking that the next day. So if they come to their very first class and, oh yeah, it was great, thank you very much, see you Thursday. And then on Thursday they go, oh my God, Wednesday was not good. So you have to try and find out what it was that set it off.
Great advice. And I know you and I, we used to always say, and what medication are you on? Because on the first day you're getting to know a client and you're asking their pain level and they're like, I have no pain, I'm great. And then they come back the next day, I was in pain. But then you find out, oh yeah, they're loaded up, or they're, you know, they've got all these pain meds, they don't feel anything. So as a trainer, you need to be aware of that too.
Yeah, yeah. But I think people are getting a little bit better. I think that they're not feeling, most people do not feel good on their narcotics. So they really try hard to get off that and onto an Advil or a Tylenol or whatever, which is far more manageable. So they will, and in the hospital, well, certainly on the North Shore, they will dose up and say to them, make sure you take your pain meds before you come and see us, because you're not going to be comfortable if you don't. And so they're well trained, but not everybody has that privilege. We are very fortunate on the North Shore of having the hospital program and then the referral to the community-based. But that is not true of Vancouver or outlying areas. They don't have anyone.
Yeah. One thing I'm curious about, and I don't think we talked about this yet, but in regards to what the exercises we were doing and exercises in the joint replacement manual for trainers, and just kind of the protocol we were using with exercises pre and post-op, was it affirmed? Did you feel like you were on the right track with that? Are there any adjustments?
Probably what is not necessarily in the manual, I don't think, and I could be, you can correct me on this, eccentric loading. They started me very early on that. So at 4 weeks, maybe, was difficult, but I did it. And then also sort of end range extension with a ball behind my knee pushing against the wall. That really helped me in a lot of ways. I think it stimulated both my quadricep muscles and my hamstring muscles. And I mean, it just sort of stimulated everything on back and front up the leg. So I found that really useful. And once I started doing that, I progressed a lot faster.
What did they have you doing for the eccentric exercise?
Just coming off the platform. So
down?
Just the platform down, and being in control down. Don't worry about the up phase, getting back up to straight. It's the down phase that's the important one.
Wow. And so that's your operated leg that you have on, and you're stepping down with the other leg. Wow. 4 weeks you did that.
Yes. Yeah.
Fantastic.
Yeah, that was really good. So other things in the manual, no, other than whatever exercise you can do that reinforces extension and flexion, do it.
Okay.
Doesn't matter how simple it is, anything, so that they can take some of those home and do them at home, just sitting in a chair and getting that leg back.
Great.
Yeah, So there's
Okay.
lots of things that are adaptable, but so I guess what I do now that I didn't used to do is that I give far more exercises for extension and flexion to the point where people will go, oh, enough already. But you need to do it.
Okay. Multiple exercises for each.
Yes.
Okay.
Yeah. And I experienced my first lack of extension client this year. She was minus 15 degrees, which doesn't mean a lot to most, but it certainly does to you and I.
Yeah.
And so again, the doctor had her wear a brace that she had to turn every day. And she had to wear it for X number of hours in a day. And probably she gained somewhere between 3 and 5 degrees, but she is still and probably will remain somewhere between 10 and who knows how much she'll gain. It's kind of hard to say.
Do we know what the cause of that was?
Miscommunication between coming out of the hospital and the exercises that she should have been doing to reinforce extension, and making sure that that leg, even though it hurts like heck, has to stay flat.
Wow.
So I think, I guess my belief before having surgery was that we're always concerned about flexion. You want at least 90 degrees, but that would be minimal, but you probably want 120 or more if you can get it. But nobody ever talked about the importance of keeping the leg flat. And it's a very unpleasant experience for most people.
Okay.
But you have to do it. And so your calf muscles are tight and you're going, well, I can't do it. And it hurts too much, but that's too bad. You have to do it. You want to be flat. And yes, the other thing was, in the hospital, they said to me, if you don't bend that knee, have that knee bending at 90 degrees, we're not going to let you go home. Well, sure, the first day I did. And then I got up to maybe 87.5 by the time I left the hospital. And I thought I was a huge failure. Not. Because it came. You work on it on a daily basis and it gradually comes. And from 90 to 115 seemed like a huge gap, but that happened rather quickly. And then after that, it just happened. I didn't really worry about it because I had the bend that I wanted.
Excellent.
Yeah. So, however, on a street bike or a mountain bike, because I couldn't get my seat height right, I was riding rather low for a little bit, and it was pushing my extension. And I was rather uncomfortable, thinking, okay, I'm not really, maybe I won't be able to walk after I get off my bike. But I was fine. It just sort of pushed me at that end range. And I have no idea what I am, but I'm the same as I am on both sides. It's probably 125 or more.
Fantastic.
Yeah.
That's great. Yeah. Now, is there anything else that I haven't asked that you want people to know or you want to share with people?
Yeah, it matters. You need to ask questions about your prosthesis, and I didn't know this before. If you have a nickel sensitivity, you need to let the surgeon know. So somehow you've got to let people know that too. It's not something they talk about a lot. So you can have a prosthesis that has a high nickel content, and I don't know what that would equate to because I'm not the expert. And you may have it in your knee, and then 5 years down the road, you go, I'm having this itchiness and irritation in the knee joint, and I can't figure it out. Well, guess what? It's probably the nickel.
Wow. And I know that one of those was linked to a specific implant, was it?
I'm the nickel content. Well, yeah. There's a higher nickel content in the Canadian, or what they use in BC or locally in Vancouver versus what they used for me in the States. There is a difference.
And so someone who doesn't have an allergic reaction should be fine, but someone who might have a sensitivity.
Yeah, and all you need is a sensitivity. So you need to ask the question, but they don't talk about it. But what I did discover recently is that they are thinking of changing the prosthesis that they use in the Vancouver area. I don't know how soon that's going to be, what it's going to look like, what the content is, whether it has a little bit more flexibility. So mine isn't like a perfect door hinge. It has a little bit of rotation at the end movement of extension. So they're all different, but just being able to ask that. And that's another big question which we get in the gym is my knees clicking. What can I do about it? Most of them do click now.
Normal.
Yeah, and it drives people crazy. I think as your muscles get stronger, there's probably a little less, and maybe long-term it might go away, but it's not something to be overly concerned about. If your x-rays have been good post-operatively, don't be concerned. Be concerned if you have pain or discomfort, but the clicking is nothing. But I've seen a lot of that lately.
Interesting.
And actually, I did have a client who said to me recently, everybody's knee clicks. And I went, maybe so, but mine does not click yet.
I wonder what's changed, because we never ran across that before.
No, we didn't. Well, we did occasionally, but not a lot.
Not a lot.
We might have had 1 in 50.
Yeah.
Yeah. But now there's a lot more.
Interesting.
And you can actually feel it when you're working with a client. They'll say, okay, I want you to put your hand on my knee and I want you to follow me through on this. And you do hear it and feel it.
That tells me it's something about the implant or the mechanics of it.
So I also heard by the grapevine that there is a gentleman, a doctor at St. Paul's who is working on a new form of implant. I don't know any more about it, whether it's done or whether he's still working on the prototype. I don't know.
Wow.
Yeah.
Things are advancing quickly.
Yeah, they are. They're changing.
And not so quickly.
Yeah, you don't know how fast your body will get better. That's something you can't predict. You can't say, well, why was somebody out walking or playing golf or on their bike at 2 months and I'm not? That's something you can't control. Just get your sleep, get your exercise, eat well.
And if someone didn't know what exercises to do and doesn't have the support of, say, a physio or healthcare supports, first of all, if they're thinking, oh, I don't need to exercise, how important is exercise for you and to your recovery?
Very important. So my philosophy is that for recovery, you have to be exercising, and to maintain the integrity of that joint, you have to exercise forever. In other words, that's it. This is your routine for the rest of your life. And in fact, I met a woman yesterday who had a hip done 10 years ago. And she said, I don't understand it. People don't seem to understand that you have to be strong. She said, I exercise every single day. I walk every day and I go to the gym every day. And if I don't do my exercises, I have pain and discomfort.
Wow. I know it was so interesting being a part of our program because we had those 3-month cycles, right? And some people, when they first came in, they're like, I'm done at 3 months, I'm graduated. And they'll never forget them saying, you told us it's like lifelong. And they just kept going like another 3 months to the year. And this participant, I think you remember her, Jane, she at the 2-year mark, she said, I'm so grateful you said keep exercising. Even for her, it was 3 days a week. So it can be realistic for people. She said, I'm still getting improvements by the 2-year mark and after the 2-year mark. And she just kept going. And
the bottom line is that no matter what, especially in the aging process, you have to keep moving.
Yeah.
As soon as you stop, you're in trouble.
Yeah.
You have to move everything to keep the circulation going, but you also have to keep those joints limber. And I have not done a lot, but I've done a little peek at research on synovial fluid with the knee. And the synovial capsule still continues to work post-operatively, but they don't know how much. And it's probably very individualized.
Yeah.
But
That's
I used to
amazing.
think once it was not your knee, that was the end of the synovial fluid. Well,
Yeah.
it is not. There is a capsule.
Amazing. So just so we explain that to the people listening, the synovial fluid gets loosened when you do exercise, and it loosens your joint, it lubricates your joint, and it actually helps you feel better. And the only way to get the synovial fluid moving is to do range of motion and gentle exercise like the bike, as well as some like not heavy duty strength exercises like barbell lifting, but strength exercises as well would activate that synovial fluid, which gives a lot of relief and lubricates the joint and makes you feel better, right?
Yes, correct.
Okay.
Correct.
We've covered so much. I don't want to take up any more of your time, but I really appreciate everything you've gone through. Is in closing out, anything else you want to add?
I don't think there is. I'm sure as soon as we say goodbye, I will think of something, but I think we've covered a lot of territory with this. We've covered a lot of topics, and there always will be lots more.
Excellent.
In terms of information to exchange or whatever.
Well, maybe we'll do another update here.
That would be great.
Thank you so much for sharing your experience and your expertise. I really, really appreciate it, and so does everyone else listening. And if anyone wants more information, you can go to website. The link will be below for you, and you can see both pre and post knee replacement exercises. So for people living with knee arthritis, and there's also exercises there for hip as well. So thank you, Susan, so much. And everyone else, keep exercising, keep moving, and know what exercises to do for yourself. All right. Thank you, everyone, for being here.